Okay, it looks like it's time for us to go ahead and get started. I believe our presenter has joined us now. Hello, everyone, and welcome to this month's Northwest ATTC webinar. I'm Jennifer Verbeck, and I'm your host for today. We're excited to have Brian Serna presenting for us today on community reinforcement approach. A couple of quick housekeeping things. Well, let's see if I could get the screen to advance. First, if you have any questions for our presenter, please type them into the chat box at any time, and we'll try to answer as many as we can at the end of the presentation. Sorry, I'm having trouble advancing the slides here. There we go. You'll also be getting an email at the end of today's webinar that has a link to the survey in it. Please make sure you take that survey. It helps us make sure we're bringing you the content you're most interested in. And that email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar. And that should be available later this afternoon. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance, and that takes us about a week to get those out. You don't need to do anything to get the certificate unless you're watching this in a group. And then if you are watching this with other people, just make sure you send us the names and email addresses for everyone who wants that certificate. And our email address is up there on the slide. It's northwest@attcnetwork.org. Next, we'll introduce our speaker, Brian Serna, who is the CEO and founder of Serna Solutions. He is also a trainer and consultant in behavioral health issues related to evidence-based practices, cultural considerations, and ethics. He has been working with the adolescent and family training community reinforcement approach since 2001. And he received his training and supervision directly from Dr. Robert J. Myers. And then with that, I'll go ahead and turn this over to you, Brian.
Thank you so much, Jennifer. It's wonderful to be here. Today, I'll be talking about the Community Reinforcement Approach, or CRA, and we'll just jump right into it. So, okay. And so I just want to make sure that I can share the slides. There we go. Okay. Should be ready. Oh, right. Everything's working the way it should. So we want to start with a tribal land acknowledgement. And so in applying a lens of cultural humility to issues of diversity, equity, and inclusion, the Northwest ATTC offers this land acknowledgement for today's event. Our work intends to reach the addiction workforce in Health and Human Services Region 10, Alaska, Idaho, Oregon, and Washington. This region rests on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join us in support of efforts to affirm tribal sovereignty and in displaying respect and gratitude for our indigenous neighbors. And I'm very happy to acknowledge that, even where I am. So I'm coming to you from Santa Fe, New Mexico, and obviously all of New Mexico was also indigenous land, and that is an awareness that I hold with me. And in my professional background, I've worked for 3 different tribes as a full-time employee, and I've consulted with probably a dozen more around the U.S. and also some Aboriginal communities in Australia. And so I do honor that deeply. So with that, oh, and I do want to say I did live and work in Oregon for a lot of years. And so I worked for a program called Adapt, which is based out of Roseburg, Oregon. We also have offices in Coos Bay, or had. I said have, like I still work there. It's been a while since I've been there, but I do miss the Northwest, and I really feel for you all with the heat wave that you are experiencing there. And so that's one of the reasons why my wife and I left and came back to where I'm from is New Mexico, and that was because of the overcast skies, where it would be 6 months before you saw the sun again sometimes. So that was my memory. The summers were hot, but I really do feel for you all experiencing that heat wave. So let's talk about what works in evidence-based treatment of addictions. So this is a quote from Dr. Bill Miller. And I will say that Bill Miller, obviously, if you don't know, he is one of the founders of motivational interviewing, along with Stephen Rolnick, and you can also throw Terry Moyers in there. That whole group of people, Miller, Moyers, and Dr. Robert Myers, they all worked in the same organization in literally the same hallway. And so a lot of what you see in CRA, it shares the same spirit with motivational interviewing. And so I'm always happy to use quotes from Dr. Bill Miller. Motivational interviewing is also something I'm very much a fan of, and I train on, and I've trained others extensively in that topic as well. So these two things go together. CRA and MI, they only complement each other. They're not the same thing, obviously, but they do complement each other really well. And so in this statement, it says the alcohol treatments with the most scientific support are the treatments that are used the least in the community. And I'm curious, do you agree with this statement? Go ahead and just pop some things into the chat. And by the way, feel free to use the chat throughout the presentation. I do like things to be interactive as much as possible, although we are a little challenged to do that in a webinar format. I do want to invite you all to use the chat. Whenever you see a question like that, or maybe I see Armando said, yay, adapt. So yay, adapt. And Marisha and Emily, they both say that they agree with that statement. And I do too, that even people who say that they do evidence-based practices, a lot of them kind of go through the motions of using evidence-based practices, but they don't necessarily do it with Fidelity. They don't receive supervision in the models. They don't get a high level of training, all of that. One of the things I did while I was in Oregon was I had a contract to be a Fidelity reviewer for the state of Oregon, where they would send me out to different programs. And what I was doing Fidelity reviews for was actually motivational interviewing. But I am sad to say that every program I went to, out of about 6 programs that I visited throughout the state of Oregon, they all said they did MI. They all welcomed us, but they actually weren't doing MI. They were doing pieces of MI to where, they would sometimes avoid an argument with the client, but in general, they weren't really using MI. They just thought they were, which is tragic and all too common. Let's see. So the statement may have been true in 2003, but I believe it may not be current now. I love that, Charles. And I'm gonna go with that. I hope that you're right with that. So what works? So why don't practitioners use the substance abuse treatments with the most empirical backing? There are some obstacles. So one obstacle is clinicians aren't aware of the effective treatments. Another obstacle is clinicians think they're actually using scientifically supported treatments when they're not. Related to that, one-time workshops are inadequate as far as supporting the training and maintenance of new therapy skills. And tape reviews and supervision post-workshops are highly recommended. I had the very good fortune to see Dr. Bill Miller give his keynote address to NIDA. It was a NIDA conference one year. And he talked about something called the training inoculation effect. And not a lot of people have heard this. And I did a quick search on the phrase, and I haven't found it anywhere. But this was his talk. He was talking about the training inoculation effect, and it's something he discovered. In Washington State, he went out there to train a group of people in motivational interviewing, and he said, I'll do it, and I won't even charge you a fee if you allow me to collect some data around our experiences together. And they said, sure, whatever you want, Dr. Miller. So he sent them a scale that measured their ability to do MI before he showed up. And then he showed up and he did the training. And it was obviously a great training. It was Dr. Bill Miller training on MI. And so he did the training, and then he tested everybody post-training, and all of them had really large improvements in their ability to use motivational interviewing. Exactly what you want to see, right? But then he repeated it at 6 months and then 12 months post-training. And what he found was that their skills in MI completely atrophied, and to where they were basically at baseline again. And the hard part was, and this is where the term training inoculation comes from, they didn't want him to come back out. They said, no, we've got it. We use it. We do motivational interviewing. Thank you for your training. We understand it. We use it. We got it. But if you just looked at the data, they weren't doing it. So they were inoculated against further training. They didn't want training, even though they went back to drifting back to what they've always done. And his hypothesis is that happens a lot with evidence-based practices. And so what he says is that what we need to do is not only do a training, but we need to do reviews. We actually have to listen to people using these models with actual clients, which is so taboo in our field unless you're in a graduate program. I think that's like the only time when people begrudgingly accept that somebody might see what they do behind the closed door. But once you're out of graduate school, it's almost like there's this magic, and nobody wants to wants to open themselves up to what actually are they doing. They say they're doing CRA, they say they're doing seeking safety, which you'll recognize Lisa Najovitz. She's also recommended this with people implementing seeking safety. They say they're doing these evidence-based practices, but really are they? And so yeah. So I'm reading what Brian contributes. He says, Bill sometimes also refers to this training inoculation effect more generally as disincentive for future learning. Totally. Michael Nunez says, yes, therapeutic drift is a problem. Mary says there may not have wanted because of paperwork, Medicaid, and bureaucracy, right? So I think Mary brings up a good point in when it comes to adopting evidence-based practices or new models of doing treatment, is that something that's put on to clinicians on top of an almost impossible situation sometimes of the demands of clinical documentation and clinical services, and you want me to do something new? So that's a real challenge, but of course that doesn't mean that we shouldn't continue to try to meet that challenge. Dell says it also implies that you're not doing things right. If you have to change, organizational change is resisted a lot. And Mitchell says, I've noticed similar tension between practitioners and self-evaluation tools too. So I love an active chat box. This is great. So ongoing consultation during the transfer of technology, which is what the ATTCs are all about, right, is considered critical. And staying true to the learning principle that gave rise to CRA, which is reinforcement, strategic reinforcement, appears to hold great promise as far as the foundation of supervision. And I will tell you, when once upon a time I was involved with Dr. Myers and we were teaching people adolescent CRA around the country, and there was this young researcher who was doing a research project on how quickly somebody will adopt an evidence-based practice like ACRA if they are incentivized to do so. So in these models, CRA, ACRA, CRAFT, we have these core procedures, and I'm going to cover those in a minute. But to get certified in these models, you have to demonstrate proficiency in the core procedures. And what this researcher was doing was he would give people $100 cash money for every procedure that they passed, they demonstrated clinical proficiency in. And he found, obviously, that when you incentivize it, when you offer people an incentive with sufficient power or magnitude, man, you get better results. And so anybody who was incentivized to go through it, they just blew away the control group that was supposed to adopt this model because it was their job versus the people who adopted this model because it's their job and they got $100 every time they pass a procedure. So why don't we do things like that in our field? It's like, again, it's like this taboo. We set up these rules that don't even make sense based on what we know about human behavior, what we know about research. We should incentivize people to do things like that. Okay. So, and this is a different study, but one researcher discovered that therapists' practice behavior was highly responsive to reinforcement. He determined that the maintenance of new skills and their use in the workplace is often it's a motivational issue. And this is something that I've seen as a consultant, that I've seen as a program director. In the Oregon program that I worked at Adapt, I had a clinician who had already retired and came out of retirement to do some more work in the addictions field. And she loathed motivational interviewing. She had such a strong reaction against it, as well as CRA and seeking safety and DBT. My job was really to implement a bunch of evidence-based practices in that program. And then I talked to her about it, but I used MI with her while she talked about her distrust, distaste for MI. I was MIing her the whole time. And then we had this meta moment where she just stops and says, "You're using motivational interviewing on me right now, aren't you?" And I said, "I am. And is it working?" And she laughed and she said, "It is." But then she quickly resigned. She said, that experience with you, I realized that I don't think I can do that. It's just not part of how I learned how to talk to people in this field. So I'm going to go back into retirement. She just bowed out. But she didn't have a high level of motivation to change. She just wanted to be celebrated for her 40 years in the field, and people would just let her do her thing. And she just wasn't interested, had no motivation to change. All right, so a good comment about outcomes-based measurements. So it's actually a question. Have outcome-based measurements like session rating scales had an impact on skill development continued with the development of practitioners? The answer is yes. And so whenever you have people, even if people don't get more consultation, if all they do are self-assessments, that on its own has been shown to have a demonstrable effect on how well they can implement a model. So if you combine that with ongoing support, right? And it's not necessarily about accountability. I feel like a lot of times people will resist that because they feel like, oh, what if I do something wrong? You're going to make me feel like I'm doing something wrong. It's not about that. It's about ongoing support, coaching, right? All of those things, helping people get better. It's a very strength-based model. So if you have self-assessment plus the coaching, that's the best of both worlds, right? And really what you want is to have an evidence-based practice champion in every single program. So if you're going to implement CRA, you would want somebody, and ideally this would be the supervisor, to learn CRA at a very deep level, to the level that they can actually teach other people how to do the model, right? Where a lot of evidence-based practice implementation falls apart is the supervisor sits back and sends all the staff to get trained in let's say CRA, but they don't necessarily take part, or if they go, they're the ones stepping out, taking all the crisis calls, right? Sometimes they'll just stay back and let all the staff go and they'll handle everything in the agency. So the staff come back and they don't get supervision in it because their clinical supervisor doesn't know the model. And then it just atrophies, right? Drift happens. So the best practice is to get the supervisors trained and actually certified in a model. And then you train the other staff, And so you do have the supervisor already equipped to, once the staff get trained, the supervisor is the on-site expert and can answer those questions, concerns, demonstrate, do role plays, all of that. So, So Mary offers something very useful. She says, as a retired skilled clinician, I can appreciate her thoughts, laugh out loud, and did not find it an easy model to learn. Find MI an easy model to learn for what it's worth. Right. Oh, and somebody says I've taken MT 3 times and I'm still confused. What's MT? Is that a typo for MI? Yes, MI. Right. So I'm so sorry to hear that, Catherine and Mary. Yeah, maybe. Yeah, I don't know what to say other than you haven't taken my MI course. Just kidding. So let's get back to CRA and let's focus on CRA for a bit. So let's talk about some early CRA studies. So the first developers in the model were George Hunt and Nate Azrin. And so they were doing this in 1973. And then Dr. Robert Myers came along right in that time frame in the 70s as a grad student. And so he did his graduate work underneath Nate Azrin and Mr. Hunt and Dr. Hunt. And so he was exposed to CRA very early. And of course, Dr. Robert Myers is my mentor. He's actually the author of these slides. So you might have noticed it says, do not duplicate without permission. That's what Dr. Myers really wants me to put on all his materials. So you can use these for your own education and training and reference. But he just doesn't want people training in the model using his materials unless he has confidence in them to be able to do that. So that's kind of the lineage of CRA. It goes Hunt and Azrin, then Azrin and Dr. Robert Myers. And there's also a gentleman who you might have heard, his name is Dr. Godley. And he runs Chestnut Health Systems. And he was also involved in these early CRA studies. And what Dr. Godley did was he developed a lot of the model for use with adolescents. And he's more well known for ACRA rather than CRA. And Dr. Myers is known for CRA, and CRAFT, which is Community Reinforcement and Family Training, where you're basically training family members how to use CRA, as well as ACRA. And so you'll see those names, Godley right there, you'll see Myers right there, but that's the lineage. And so in Hunt and Azrin, what they did, keep in mind back in the early 70s, treatment as usual was primarily 12-step based, and it was primarily like an each one, teach one kind of model, where all the program staff were people who were graduates of the program. That was treatment as usual in most addiction centers around the country at that time. Unless it was like a faith-based model, there was some of that happening for sure. There was even some cults like Synanon happening. And so we have these scientists who are very much social learning scientists. So by the way, CRA is often thought of as a CBT model. It's not a CBT model, it's a behavioral model with its roots in behavioral theories and social learning theory. And so we have Hunt and Azrin saying, you know what, we don't want to do the steps. We're going to try something completely different. And instead, we are going to use what we know from social learning models and reinforcement. And we're going to try to get people to do some behavioral changes that set them up for the best outcome, rather than this internal cognitive spiritual process, which is really what the 12-step offers. And I'm not knocking 12-step. And by the way, CRA can be compatible with some 12-step attendance also, and they'll become more clear a little bit later. But this is what they did: job finding, behavioral, marital therapy, social and leisure counseling, reinforcer access counseling. I love the idea of a social club. What they used to do is they basically they borrowed a VFW and they pulled out all the booze and locked it in a closet somewhere. And so their clients got to go to the VFW, shoot pool, dance at the jukebox, order drinks that were tasty but non-alcoholic. And that was part of the program. And I don't really know of a program that still does that sort of thing, right? And the running joke that Bob told me was way back then, they used to say that someone's ready to graduate as soon as they ask somebody else to dance completely sober. That's when we know they're ready to graduate the program. But it's important that people have these experiences, you know, without being substance involved. And so that's what they did. They also had some home visits, and basically they spent 5 hours per client with that person. And this is what they found. So they're comparing it towards traditional approaches versus CRA. And, you know, the slide really speaks for itself. What we're looking at are drink days, days away from family, days separated and divorced. Those are the columns that are highlighted here. And you can see drastic reductions in almost every measure that they used in that study. So then we go a few years later, they did a new and improved CRA. And part of the improvements were anabuse, disulfiram, as well as problem prevention, which is kind of a precursor to relapse prevention, looking at high-risk situations or high-risk problems. And there was a buddy system. So they borrowed that concept of that you get from the fellowship of 12-step groups, and they had a buddy system. So you had somebody to go eat with, you had somebody to do laundry with, you just had somebody looking out for you in the new and improved. They also had early warning mood monitoring, and basically the buddy would just notice if you became kind of isolated and despondent before you relapsed, knowing that emotional negative states are often the most commonly cited precursor to a relapse. If somebody was in a negative emotional space, the buddy would alert the staff would do basically, you know, an intervention with them and just say, what's going on? You know, people are worried about you, how can we help? And so that was new and improved CRA in 76. And we're looking at drink days, jobless days, days away from family, or days institutionalized. So that includes residential care, hospitalization, and incarceration. And you can see that CRA blew the doors off the competition back then. So then we have this outpatient study. And so there were 43 outpatient people that were alcohol dependent. And they had 3 groups. They had traditional treatment plus anabuse, and CRA plus anabuse. Why? Why did they do this? Because critics of that study we just talked about said, yeah, you got great results, but it's probably due to the anabuse. You know, I bet if we just did traditional treatment plus anabuse, we would get the same results you did. So they said, I'll take that bet, my friend. And they designed a study where they're really comparing traditional treatment plus anabuse versus CRA plus anabuse. And so let's see what they found here. So 6 months follow-up, CRA plus anabuse had a 97% of their days had been abstinent over the prior 6 months. That's staggering. And then traditional, they did really well, honestly. They did spectacular too, just not 97% spectacular. They did 74% of their days were absent over the previous 6 months, whereas traditional, still good, by the way, 45%. Let's see. So then we did CRA, we're going to look at CRA with homeless, alcohol-dependent individuals. This was done by doctors Jane Ellen Smith and Dr. Myers. And this was funded by NIAAA. It was done right here in New Mexico, in Albuquerque, to be specific. So what was the primary questions that they were trying to address? Is CRA better than a day shelter standard program for treating drinking problems among homeless individuals? So the idea here was community reinforcement approach worked really well for people who had intact communities, intact families, right? So the idea with community reinforcement approach is that you are working with somebody to rearrange the reinforcers in their environment or community so that it supports reduction of use and maybe even abstinence. So criticism of the model was there's no way this would work for homeless individuals because they're not part of a community, which is naive, right? Anybody in this workshop who's worked with homeless individuals, you know that their community is probably more vibrant than your typical isolated middle income family, right? Their community is pretty robust, actually. But you know, the idea, so the thinking is, yeah, they have a community, but their community just reinforces negative behaviors. And so they said, okay, let's see how it goes. So they're doing CRA here with homeless individuals. And they also looked at what are the effects of the two treatments on non-drinking variables. And so let's see what they found. This is the first time they studied CRA in a group, right? Instead of doing CRA one-on-one, they were using a group here. And actually they did a hybrid of group and individual. So you can see here what they did in the group. A lot of it was the skills training components of CRA. So problem solving skills, communication, drink and drug refusal skills, independent living skills, and it goes on from there. In the standard treatment group, this is what they got. The day shelter program, which is basically helping people find meaningful activities to keep them busy during the day. They had AA meetings, a 12-step counselor, job service program, and a VA benefits advisor, because unfortunately, a lot of our homeless people are veterans. And so all participants were housed in this study. The normal length of stay was 3 months. They could have extended stays if they were working and they saved some money. They were all given random breathalyzer tests. One of the things I love about this study was, let's say somebody relapses, right? In a lot of studies or a lot of treatment programs, a relapse means you get booted. You're exited out the program, unceremoniously sometimes. That doesn't make sense. It doesn't make sense to treat people for addictive behaviors and then they engage in an addictive behavior and then we withhold treatment from them. It does not make sense, yet it's still a very common practice that if you have a relapse and you're in a program for drug and alcohol, you are no longer welcome in the program. What I love about this study is you breathe into the breathalyzer, and if there's alcohol in your breath, it doesn't mean they take away your housing, right? It doesn't mean you're homeless again, and which means that you'll actually start drinking more. All it meant was you got to chill out until you can blow a zero again. You just got to wait. Have a sandwich. You want some coffee? We'll give you a breathalyzer again in about an hour. See where you're at, and as soon as you blow zero, you're welcome to go back into your apartment. Gosh, that makes a lot of sense, right? From a harm reduction perspective, just from a logistical perspective of we're treating people for addictions, they need some support, not for us to withhold treatment if they don't do everything perfectly. So this is what they found. We're looking at drinks per week by condition. So medium SECs. SECs is an acronym for standard ethanol content, which is crucial when you're doing studies with homeless individuals, because they don't automatically drink standard drinks. So you want to convert that into SECs. And so the standard group is the red line. The CRA is the yellow line. And of course, you can see a huge difference between the two conditions there. And now we're looking at percent homelessness by condition. And so the red is standard and the green is CRA. So there was a period right at 6 months where they were almost identical in the amount of people that were either homeless or not. But then that kind of goes back down, and you see more of a separation the longer you look down the road, which is kind of what you would expect in a skills training program. The idea is that you teach people skills that they then slowly internalize and generalize to navigating life, and their life becomes more and more manageable as time goes on, which means they get more stable as time goes on. All right. So the last bit of research that we're going to talk about, these are meta-analysis studies. And so we have 4 of them here that look at different eras, kind of different time periods. We have from 85, 91, 96, and then 2003. And these are all the meta-analysis of clinical trials for the treatments of alcohol use disorders. And I'm not going to spend a lot of time on these ones, just to point out that CRA is always one of those approaches that rises to the top as having the most reliable and most robust effect. And when you look at the literature. So these are some other selected CRA clinical trials. And if you really are interested in research, I do recommend that you go to the website of Dr. Myers. That's robertjmyersphd.com. And you can look under publications, and he actually has a monograph of CRA research where you can look at a lot of different studies. But I do like to end on this slide just to show people that there's not really an addictive behavior out there that CRA hasn't shown some promise in treating. And, you know, on this slide, we see things like stimulant use, alcohol use, opioid use, all of those things. But I'll also just throw in there that this has been used to address pathological and problem gambling. And so it's been used for a lot of different circumstances. And so Catherine says, has there been any research on CRA specifically for, oh, that's Deb. I was wondering about stimulant use. So here we have cocaine, a lot of cocaine. There are some on methamphetamines, and there are more recent studies on CRA, but there are more adaptations to the model. You know, once you, I feel like once you accumulate as much research as CRA has had since the 70s, there comes a point at which where it doesn't make a whole lot of sense to continually do more and more studies on it, unless you're doing you know, a novel adaptation with the model. And but there are, you know, there's a study out there by Higgins, the CRA plus vouchers, you know, and a lot of people cite that study to make the case for contingency management. And it does, you know, contingency management is part of that study, but so is CRA is a big part of the Higgins study. You know, oh, there, Higgins and others. So I guess it was on cocaine, but I know that there's studies on methamphetamine. I just need to. Yep. So I'm just scanning the chat box. I can do some more research. Just email me and say I'm really interested in specific studies on methamphetamine, and I can dig those up. I can ask Dr. Myers, and I know I've asked him that before, and he dumped some more studies on me that I just didn't incorporate into this slide deck. So this is just continuing on. Oh, look, and so this is getting a little bit more recent, but still nothing specific on methamphetamines. And so we have all this research. We have reams of research. It's a very well-established evidence-based practice. So why isn't it used more? So part of it has to do with limited accessibility. In other words, there's just not a lot of people trained in the model. And also traditional treatment models have very strong roots. The disease model, computational models, etc. And again, what I found in all of my years of training and consulting is some of those folks who have really strong roots in the disease model, they will do some lip service to a model like CRA. But once you scratch beneath the surface, it's just a veneer of using evidence-based practice, but they're not really using it. I did a review in New Mexico of a program who had CRA listed on their website as one of their models. And I was just touring the facility, and I said, you know, I just got to say, it's really encouraging that you guys are all using CRA. And the clinical director just looked at me and said, I'm sorry, what? CRA, community reinforcement approach. It says on your website you use CRA. And they say, I'm not familiar with that model. I'm going to have to ask them to change that on our website. And I was just floored. You know, here I was excited to meet a program that was implementing CRA, and they were very much a 12-step oriented program. And again, I don't have anything negative to say about 12-step, but it would be nice to also see an evidence-based practice like CRA implemented as well. So it's also hard to teach an old dog new tricks, the training inoculation effect. People often will say we already do that when they don't. And also CRA isn't sexy. And that's actually a phrase directly from Dr. Robert Myers. And when I asked him, what does he think is sexy? he says, like there's always sexy things out there. Like for a while it was Matrix. Now it might be, equine therapy, or it might be psychedelics, using psychedelics. So there's always like, something sexy coming down the road, and people forget about this model that's been here since the 70s. And so it's just not like this new thing that gets a lot of attention. All right. So let's just talk briefly about fidelity. What is fidelity, right? So fidelity, it basically means to be faithful to, right? And so fidelity, it means that you are faithful to the model, so that, and the idea behind fidelity and evidence-based practice is you're faithful to the model so that you can get the outcomes that the research says that you're going to get, right? If you dilute a model, you can't expect to get the same outcomes, right? And at one point, a researcher explained it to me using the metaphor of antibiotics, right? If you don't follow the instructions with the antibiotics and you stop taking it as soon as you feel better, you're likely to get a reinfection, and that reinfection might even be more robust than the first infection. And so it doesn't make sense to take only a little bit, right? But people in our field do that a lot. They'll take a little bit. Like with CRA, they might say, "Ooh, I really like the happiness scale. So let's do the happiness scale, and now we're doing CRA." But they're not doing any of the other skills training pieces. They just really loved the happiness scale. So they're not going to get the same outcomes that you would see that, some of the research I just touched on tell you can expect. So that's why you want to keep fidelity. You want to keep it to give yourselves the best chance at having the best outcomes. So what prevents you and your staff from developing CRA skills, or what obstacles might prevent you and your staff from developing skills related to adopting an evidence-based practice like CRA? I'm wondering if anybody has any thoughts on that they'd like to go ahead and put into the chat box, and we'll come back to that. So what is the goal of CRA? So I said this before, but I'll go ahead and say it again. The goal is to rearrange vocational, family, and social reinforcers of the alcoholic, such that time out from these reinforcers would occur if that person began to drink. So I do want to say that this quote is an artifact of its time, being that it was published in 1973. And so a lot of addiction treatment back then was focused on alcoholism, or a substance use disorder that's alcohol specific. And you also see the he word in there, so it's not as inclusive as today's standards would allow. But I use this quote still, again, because I think it's really important for us to realize that this approach has been around since the 70s, and it's been helping people since the 70s. So CRA is non-confrontational. So CRA shares that similar spirit as motivational interviewing. And just by the way, if any of you are working with veterans, Dr. Robert Myers and Dr. Bill Miller, so MI and CRA, they co-authored a 2 workbook series for veterans returning back from service that you can order through the Change Company. And I have no vested interest in you purchasing anything. But if you're interested in that, I think it's a really good example of the collaboration between both schools of thought around CRA and motivational interviewing, is those workbooks that they both co-authored. Even though the CRA is non-confrontational, it is much more than simply being nice to clients. Even though CRA therapists do not use confrontation, we do set limits and boundaries. We strategically use reinforcement principles to address behaviors that interfere with the treatment process. And we allow natural negative consequences of problematic client behaviors. And so, CRA is it's non-confrontational, but it's also just very matter of fact. And one example that they give in some of the CRA manuals are a client who's on probation is not coming to sessions. You just say, well, I'm sorry that you're unable to make it to our session today. At this point, you've sufficiently missed enough sessions to where I will need to notify your probation officer that you're no longer a client of ours due to lack of attendance. I wish you the best. And then that, you just, that's just a natural consequence of them not showing up. And so you never have to be confrontational. You never have to be the heavy. Those kind of things work themselves out. Usually the response to that conversation is, oh, I'm sorry, please don't contact my probation officer. I'll be right there, or I'll be there next time. And so that's one of the ways that CRA uses just behaviorism to manage some client behaviors. These are the core procedures of the community reinforcement approach. So we have orientation and a rapport building session at the front end, and then we can do any number of things. One of the reasons why there aren't manuals set up, kind of like the matrix model has a very user-friendly manual, it's because with CRA, it demands a little bit more from the clinician, and that there's not a session 1 do this, session 2 do this, session 3 do that kind of approach. Basically, what you're doing is you're identifying what the client needs week to week, and then you are linking that to a skill, to skills training that needs to happen, and you do that week to week. And so what that can look like is you do the orientation rapport session, and the person right away is facing some problems with getting a job. So you go right into problem solving, and you might even do some job finding skills right away. Before you do a functional analysis, before you do a happiness scale, before you do anything else, you do those skills so that they can see the value of the model and the value of spending time with you, right? But typically what you're going to do is you'll do a functional analysis near the beginning, just as a way to develop rapport, to get an understanding of the world that person lives in. And another tool that's excellent for both of those things is the happiness scale. So you'll do that near the beginning of your time with somebody in their treatment episode. And then from there, you're focusing on skill development, communication skills, pro-social counseling. So the skills it takes to get them to link into behaviors that can compete with substance use, behaviors that promote abstinence or reduction of use, all of that. And we have sobriety sampling and problem solving, and I'll get a little bit further into that as we go forward. So that first session, we really are focusing on building rapport, staying client focused. We use positive reinforcement right out of the gate. We thank somebody for showing up. We provide a basic overview of what we're doing with CRA, and what that might sound like is I'll tell a client, with this model, what I'm really interested in is improving your life. I want your life to feel better. I want you to be happier when you're not using, or you've reduced your use, than it is while you're using. That's the whole purpose of the model. That's what we're trying to do, is improve your life so that you don't need to use to escape your life. You can actually just live in your life. So that, that's a very informal way of providing an overview of the basic philosophy. And then we also just touch on some of the other procedures, basically trying to highlight the ones that we know are meaningful to the client sitting across from us. And, they need to find a job. We say we do job skills. They need to, there's a lot of conflict at home with their significant other, or with their caregivers. Maybe they live with their parents. We highlight that and we say, we're going to teach you new ways to communicate so that there's less conflict and less fighting and less negativity in your life. And some people will really attach to that. So that's what we're trying to do there. And so with the overview of the philosophy, these are some other pointers that we give to people. And with that piece of it, one thing you might say to a client is everything you do for a reason. We want to help you find new ways to get what you need. Life is hard and you have been using substances to deal with it. Together we will try new ways to deal with the hardness of life. Most of us weren't given all the tools we need to deal with life. This program will look at your strengths and give you some new tools that you haven't had before. All right, so outlining the procedures with your client. This is part of informed consent. People need to know what they're getting into. It also sets an expectation that they are going to learn something, right? They're not just going to come in and just BS with somebody and just let them know what happened in their life and just say, well, you'll never guess what happened this week, right? It's much more, it's very skills focused. And so we do that right away. We say, this is what you're going to learn in here, so that they know that it's more didactic in that way. It takes the mystery out of treatment, creating an equal playing field. So some other items covered at first contact, we emphasize their autonomy, their independence. We begin to establish their reinforcers, which is another way of saying we begin to look at their motivators. What can we use to reinforce their attendance? What can we use to reinforce their desire to change? And we want to explain the basic structure of CRA sessions, which basically is the client comes into a session, you review the homework, which is some behavioral intervention like communication skills, or drink and drug refusal skills, problem solving skills, whatever it is. You review the homework, and then you teach them something new, or if they didn't get the homework assignment down, you just redo the same skill. And this happens a lot with communication skills, where people think they get it, but then they try it out and it doesn't work, and it turns out they don't really get it. So you just wind up working on communication skills for 2-3 sessions, right? So again, it's client-led. And then you assign that skill for homework. Whatever you taught them in that session is what gets assigned as homework. So you can see how heavy this is weighted towards behavioral change. And the idea is that insights will come often after the behavioral change. I think a lot of other models think that the insights cause behavioral change. In a behavioral model like this, and also in my experience, I've seen a lot of insight come after the fact, right? It's after somebody starts working out that they start having the insights as to why it's good for them. It's after the person starts writing or painting that they can articulate what it does for them. So that's kind of the underlying premise in these behavioral models is behavior drives insight. Insight doesn't always drive behavior change. All right, so then we do a functional analysis of addictive behaviors. And by the way, I do expect us to go right up until the end of the training, right at 2. There was a thought that I might have to leave a little early. I do not. And so we will be going right up until the end. I am going to try and go a little bit quicker here. A functional analysis is basically you analyzing the function of a behavior. You can analyze a negative behavior like substance use. You can analyze a positive behavior like going to an AA meeting. You can analyze any behavior. And if you're analyzing a negative behavior, you're trying to identify the triggers as well as the payoffs from that behavior so that you can begin to interrupt those triggers, and you can identify behaviors that can compete with that negative behavior. So if somebody's using substances to alleviate anxiety, you want to identify behaviors that alleviate anxiety that don't involve substances. And that all comes from the functional analysis, right? So let's go to the happiness scale. The happiness scale is a snapshot of a life. So basically you have somebody rate themselves on a scale of 1 to 10 in all these different life areas. And you're trying to get them to appreciate that life is complex, that it's not all or nothing. It's not all black and all white. It's not all doom or euphoria. There's a lot of gray in there. And so that's why we have this 10-point scale for all of these different life issues. And also, it really gives us an opportunity as a clinician to get to know them and to really see what's working and to identify what's working and build on the strengths as well as addressing the deficits. So some other skills training that we do: communication skills, drink and drug refusal skills, problem solving skills, job finding, anger management. You can do stress management. And by the way, anything that's skills-based, you can use alongside CRA, and it doesn't sacrifice the fidelity of CRA as long as it's a skills training component. So what that can mean in the real world is I had an IOP program at Adapt that was built on CRA and dialectical behavioral therapy. And so those things really just went together. You know, it's all skills training. And so they really kind of blended well. And so, you know, it wouldn't blend well in the actual session. One would be, the Tuesday morning group would be our core group, which was CRA based. And then Thursday, when they come back, they go to a DBT emotional regulation group. And that doesn't interfere with the fidelity of the CRA model. It's not counter to the CRA model. It's another approach that's addressing skill deficits. So with social recreational counseling, this is also related to something called the sobriety sampling procedure. Basically, what we're trying to do is getting people to sample new ways of being in the world. So you can have them sample a new social activity, a new recreational activity, and of course, you can have them sample sobriety. And in a way, CRA in the 70s with the sobriety sampling model, they were doing harm reduction in a very real way before a lot of folks, that was even an option for them to think about. And so harm reduction is, you know, we're gonna sample sobriety this week. And I'm not saying you have to commit to lifelong abstinence. We're just sampling it. We'll see what it tastes like. And I'll meet with you next week and you can tell me what it was like to go through the weekend without using a substance. All right, so we are gonna move forward a little bit here and talk about couples relationship therapy. And that is something that a lot of clinicians stay away from, working with couples because they feel like they're not equipped, they're not a couples counselor. But in CRA, if you get trained in the model, we actually really make it self-explanatory and give you a really tight model of how you do couples therapy. And this is my favorite part of it. It's called the daily reminder to be nice. And it's just, just an inventory of, did you do these things? Express affection to your partner, compliment your partner, give your partner any pleasant surprises, express affection to your partner. So the idea is that the person would do at least one of these things every day. And then they would just watch and see if their relationship improved. And of course, 9 times out of 10, they would report an improvement in their relationship just by doing these behaviors. They would experience just less conflict, more intimacy, all of those things. So some common mistakes in implementing CRA: losing sight of the client's reinforcers, failing to involve those significant others in treatment, like not doing the couple sessions because you're a little intimidated by doing the couples work, not emphasizing the importance of having a meaningful, satisfying social and recreational life, not having a job that is meaningful. Those are the main points there. And so just a brief word about training and certification. This is a model that shows how that works. So there's a CRA trainer that would then train the program, and then they would certify CRA clinicians and a CRA supervisor. And then that certified supervisor can then certify other people in the organization, as long as it's needed. All of the certifications in CRA, by the way, they're lifelong, they don't expire, unlike some other models out there. It's just a matter of, can you demonstrate you know what you're doing? Once you could do that, we believe you for the rest of your life. Go on and do CRA. So if you're interested in certification, you can send me an email, and I'll give you the email on the last slide here. Or you can contact Dr. Robert Myers directly, because he does certification, and I do certification as well, but I run that all through Dr. Myers anyway. This is the first CRA Therapist Manual. It's called the Clinical Guide to Alcoholism Treatment, the Community Reinforcement Approach. I do recommend that you get it. It's a very cheap purchase on Amazon, about, I want to say between $10 and $15. This is the monograph on CRA research, and this is how you get a hold of me. And so We have less than a minute left, but I do encourage you to send me an email if you have more questions or you want to contact me. It's brian@sernasolutionsllc.com. I do hope you got a lot out of this webinar. I know it's very brief and targeted, but it was chock full of information, so I do hope you got a lot. Please fill out the survey.
Thank you, Brian. We appreciate you presenting for us today. Great information. And thank you to our participants for joining us today. Make sure that you fill out our survey. It's in the link is in the chat box, and you'll also be getting an email with the link. And join us for our next webinar on July 28th. That's titled Harm Reduction Service Use and Delivery, Lessons Learned from Vancouver, Canada. And that will be presented by Dr. Jenna Van Drainen. So thank you everyone for your time today, and have a good one.
Thank you, everybody. Take care.